Okay, all right. Good morning, or whenever time you're listening to this, hopefully before lecture today, Friday. Last week, we talked about the special senses, and we covered the chemical senses. We got into taste and smell, and how the taste buds work, and how taste sensations work. We talked about the the nerves, the cranial nerves responsible for taste, and what parts of the tongue. We also talked about gustatory pathway, smell, and the very thin barrier there, the olfactory cells up there, and the disorders of the chemical senses. We talked about the eye and vision, eye muscles, the anatomy of the eyeball, and also we got into blood supply of the retina, the internal chambers and fluids, and lens. This recording, this lecture, is going to continue on this overview. We'll be discussing the visual pathways to the cerebral cortex, the disorders of the eye and vision, the ear, the external ear and equilibrium goes hand in hand, and the disorders of the equilibrium and hearing, and also what the special senses do as we age. So the eye, as an optical device, we have structures in the eye that bend light rays. We talked a little bit about the cells last week, the rods and cones. But these light rays converge on the retina at the single focal point. And this light bending structure is called refractory media, or the lens, of course, the cornea, and the humors. We have accommodation, which is the curvature of the lens that is adjustable. And as we mentioned last week, the eye can actually change shape, and this allows for focusing on nearby objects. As you can see here, the top picture has the lens that flattens for distance vision. So you can see the lens there, and then on the bottom picture, it bulges for close vision. And you have the relaxed ciliary muscles that are on the superior part of that lens, and the inferior part that um, pull the eye thinner. And then you have the tightened ciliary zone that actually contract and make it thinner. You have your flattened lens, and as you can see, the letter R, how it's inverted, going through and reverted on the back side. The image is actually reversed. And then for close vision, as you can see, the lens actually increases in size, and the parasympathetic input, parasympathetic is rest and relax, contracts the ciliary muscle, and this loosens the ciliary zonal and allows the lens to bulge. And so, again, you have the divergent rays from a close object. As you can see, the R is a lot closer, so that lens will go ahead and increase in size. Clinical applications, any type of focusing disorders. So myopic eye is nearsighted, and hyperopic eye is farsighted. So people will have, um, readers and things like that. As they age, their eyes actually change. And so the hyperopic, the farsighted, the eyeball is too short, or the myopic, nearsighted, the eyeball is too long. And so we need to wear corrective lenses to actually fix that. As you can see below, the myopic eye, with the nearsighted, we have a concave lens, moves focal point further back. And the corrected hyperopic eye, farsightedness, you have a convex lens that moves focal point forward. So that's your corrected. Most visual information travels to the cerebral cortex, The cerebral cortex is responsible for conscious seeing. So, and this is very important because it's your perception, right, of your past experiences and your memory and all those things. Those are your conscious seeing. So, they've actually run studies where it was a dark lit room and a flashlight was pointed at an object. Maybe it was a human being holding an object in his hand, and the light was shut off, and they were asked, what did you see? And they say, well, I saw a man with a knife or a gun, and they turned the lights on, and the man was holding like an ice cream cone or a garden hose or something like that. So it's all about perception and seeing, brain picking up enough information during that flashlight picture and seeing and memory. So other pathways travel to nuclei in the midbrain and the diencephalon. So the diencephalon comes into play. The visual pathways to the cerebral cortex, the pathway begins at the retina, as we've shown in the past few slides. And the light activates these photoreceptors that we talked about last week. These photoreceptors signal bipolar cells. Bipolar, you know that because we covered that in the nervous system block. So based off your education and your knowledge, you know that bipolar cells signal ganglion cells. And the axons are where? Axons leave the central nervous system, right? So they're in the peripheral nervous system of ganglion cells. They exit the eye as the optic nerve. The optic tract sends axons to the lateral geniculate nucleus of the thalamus and synapse with the thalamic neurons. The fibers of the optic radiation reach the primary visual cortex, and partial decussation of axons take place, which is responsible for depth perception. And some people lose their sense of depth perception as they get older. They lose their balance, what their brain is actually telling them from what they actually feel with their feet. And back in the day, we were taught to use and to feel with our feet, but to use other senses, our special senses, to actually accommodate for depth perceptions. For example, if you were blindfolded and um, you know, if there's a hallway full of toys and objects, and you could actually feel with your feet. And we used to go through this training where you had to not make any noise, even though there was objects in the hallway. So if you felt with your feet and felt something similar to what a blind person would do, they would move around and negotiate these objects throughout the hallway. And so depth perception is another thing. It's actually using your vision, but it also um, is related because of your proprioception and the things that you're accommodating to, for your depth perception. Some axons from the optic tracts branch to the midbrain to include the superior colliculi and the pretectal nuclei. Other branches from the optic tracts are branch to the suprachiasmatic nucleus. So this is all involving the brain. I would revise the central nervous system and also read some of the chapters in this chapter of the Pearson book and the text, and get more familiar with these parts. I'll let you know what's going to be important on the test, but understand based on this slide that some axons from the optic tracts, they branch to the midbrain. And I'll leave it up to you to study these particular parts of the brain. So here's a picture. You have some artwork to the left and the actual brain off to the right. The corpus callosum is pretty interesting. On the bottom, it communicates between the left and right halves. But here we have the visual pathway to the brain in the visual fields, We talked about peripheral vision last week, and that the rods are responsible to pick up more things from the side, from the lateral side during darker, um, darker lit areas or poor lit areas, and that our cones pick up color from the front and more focusing. But this is just a good example of the visual fields of the two eyes that overlap considerably. As you can see, they overlap. And there's a fixation point. You'll be getting into some neuro testing with the use of objects where you have the patient follow your finger or follow a pen light and all these kind of things, and you can determine if there's any nerve damage to the ocular motor, to the trochlear, to the abducens, to the different nerves that control the eyeball and the eye muscles. And also can determine if there's any brain injuries by the pupils that react to light or the absence of light. We talked about last week that pinpoint pupils are indicative of heroin, and dilated pupils are cocaine. Remember those two. You can. It's important for your clinical test, and not only in this class, but in future classes, your pharmacology, and so forth. So this is just a picture. Get familiarized with these visual fields. Not too important, but just get familiarized with, understand that they both have overlapping areas. So the disorders of the eye and vision, you have retinopathy of prematurity, and this happens when blood vessels grow within the eyes of premature infants, and vessels have weak walls, and what happens is it causes hemorrhaging and blindness. So very important to get that checked out. And then we have trachoma, which is contagious infection of the conjunctiva. And moving on to the ear, we have hearing in equilibrium. You know that the ear is a receptor organ for hearing in equilibrium. And based off your nervous system knowledge, you know that there's going to be some nerves inside. We'll cover those. So remember that the ear is composed of three main regions: the external ear, which functions in hearing; the middle ear functions in hearing as well; and the internal ear has both hearing and your equilibrium. The external ear is composed of the auricle, which is the pinna that helps direct the sound in. So it's kind of like a funnel, your funnels that exit the side of your head. And the external acoustic meatus contains hairs, sebaceous glands, and ceruminous glands. So if you ever use a temperature reader that checks the tympanic temperature, you want to make sure that the ear is clear of any ceruminous glands or fluid or earwax, because cerumen they call it. Reason being is it actually degrades the sensor and it gives false readings. Also, when you're doing auricular acupuncture, you want to make sure. Sometimes it's embarrassing for the patient, so you have to kind of use this with kid gloves, or just take a cotton ball and some alcohol and clean most of the gross stuff out of there, the majority of it out of there. Most of the patients are pretty well aware, but if you go to an ear clinic where you're working with populations where folks don't have access to showers and bathing, it could be problemsome. So, and in this case, sometimes it's just best to go in the scalp or in the cleanest area. Tympanic membrane, we want to know that it forms the boundary between the external and middle ear. I would put an asterisk next to that point. And here's the structure of the ear. As you can see, we talked about the auricle, which is the funnel. You have your helix and your lobule. You'll learn all about the parts of the ear at the micro level when you get into auricular acupuncture, because each one of these points and parts of the ear correspond to a part of the body depending on what system you're using. And you'll learn a lot of different systems with auricular acupuncture. And also you'll learn the French. The French actually created a system that you'll learn about during your auricular training. Of course, we have our external ear, and then the external acoustic meatus. And both these have different embryological beginnings of what parts develop first. And then you have your tympanic membrane. Again, that's your barrier, right? We talked about that earlier between the external and internal ear. The middle ear includes the just past the tympanic membrane, and then you've got your incus and different hearing devices in there, and then you have your internal ear, which is your labyrinth, and that is your pharyngo-tympanic auditory tube. We'll go over some of those parts here. So again, the middle ear is composed of the tympanic cavity, small air-filled space located within the petrous part of the temporal bone, and the medial wall is penetrated by an oval window and a round window. You have your pharyngotympanic tube, which is your auditory tube that links the middle ear and the pharynx. So there's a connection in there. There's some communication back and through there. And then going into the structure of the ear, this is your middle ear portion. You have your malleus and your incus and your stapes. So understand those three parts. If you're required to ID those, the same picture, make sure you know those in order. So it's MIS in order. And those are your auditory ossicles. And just prior to that, exterior or lateral to those auditory ossicles gives rise to the tympanic membrane. Again, that's your separation between the external and internal ear. Moving to the right, you have your semicircular canals, your vestibular nerve right there that runs into the vestibule, and your cochlear nerve. And then your cochlea, which is like a snail shell looking aspect. Then you have a tube that runs down. It's called the pharyngotympanic auditory tube. And we'll go and describe this even further. So again, the middle ear, as we said, the malleus attaches to the eardrum. These are the smallest bones in the body. Put a check mark next to that. Red star, or whatever you want to do, underline, highlight, and then know how to identify the malleus, the incus, and the stapes. The tensor tympani and the stapedius are two tiny skeletal muscles in the middle ear cavity. And here's another picture. You have your malleus and incus and your stapes all together. And this is actually a different picture. It's a bivalve picture, so you can see it internally. And then your internal ear, also called the labyrinth, which lies within the petrous part of the temporal bone. And you have your bony labyrinth, which is a cavity consisted of three parts. And so understand what these three parts are. They're the semicircular canals, the vestibule, and the cochlea. And here is another picture, getting back to identifying what is. If you see this picture, know where the cochlea is, know where the malleus, incus, and stapes are. Know the difference, know the division between the external and internal ear. Know that part we mentioned before. tympanic membrane, and getting into the internal ear. At a deeper level, we have a series of membrane-walled sacs and ducts that fit within the bony labyrinth, and they consist of three main parts: the semicircular ducts, the utricle and saccule, and the cochlear duct. The membranous labyrinth, it's filled with endolymph, and it's confined to the membranous labyrinth, and the bony labyrinth is filled with perilymph and is continuous with cerebral spinal fluid that we covered during your nervous system lecture. And you know what cerebral spinal fluid is. You know that it runs in the tracts and helps for protection. It also runs down the spinal cord, and when they do taps, they can actually withdraw spinal fluid and see what's going on in there, whether it has bacterial meningitis in there. It also is responsible for increased cranial pressure with head injuries. Your symptoms, your vitals will actually change as a result of increased cranial pressure because of the cerebral spinal fluid has nowhere to go, and it's stuck right in through there. We covered that in length. I would advise you to revise that area that we talked about. Where is cerebral spinal fluid created? It's going to be on your final exam. Where is cerebral spinal fluid created? Where is it manufactured? In the brain, right? Know that. I would revise that. You can. And also, you have your inner ear, which is the basic structures of the bony and membranous labyrinths. This is just a table describing for you that allows you to remember what's going on in the functions of these bony labyrinths. So understand that the semicircular canals and the vestibule, their function is equilibrium and rotational angular acceleration of the head. And so I would break this up and revise this. Also, know that the cochlea is not responsible for equilibrium, right? Just hearing. And then over here, you have static equilibrium and linear acceleration of the head. So this is important. So know this stuff here. And we'll break this down even further to the internal ear. Got a more serious picture of one. Isolated from the middle ear is got this alien looking structure here. But you see the stapes in the oval window down below. You have a round window. You have a cochlear duct in the cochlea. And what's important about this slide, I want you to know how it's embedded with the temporal bone, and that you have nerves that go into the internal ear, and know that you have a vestibular nerve. Know that the facial nerve comes through there. The facial nerve is also responsible for taste in the anterior 2/3 of your tongue. Your glossopharyngeal nerve, which is not pictured here, is responsible for taste in the anterior 1/3 of your tongue, or the posterior 1/3 of your tongue, pardon me. Know what nerves come into the internal ear. Just giving you a quick review, going back to the prior lectures of stuff that we have covered so that you could take good note of that and understand those are good high yield areas that you need to remember. Now, the cochlea is a spiraling chamber in the bony labyrinth, and this coils around a pilar bone. The mediolus and the osseous spiralamina is a spiral bone in the mediolus. The cochlear nerve runs through the core of the mediolus, as seen here. So based off your knowledge, you know that this nerve goes into this area, and know that based off your knowledge, what kind of afferent and efferent things are going on through there. Right? So you have your spiral ganglion, your osseous spiral lamina. Just understand that the cochlear nerve, which is a division of the vestibulocochlear nerve. So you may see a question. Not only would you have to memorize the cranial nerves, you know that this is the vestibulocochlear. However you memorize it, you're going to need to know if it's sensory or motor or both. You're going to need to know what number it's associated with. And if I say the cochlear nerve is a division of the A, vestibulocochlear nerve, B, facial nerve, C, and on. And you'll have to pick. So know that the vestibulocochlear nerve gives rise to the cochlear nerve, which reaches into the cochlea. And so there you have it. Although the cochlear nerve is not one of the cranial nerves, it actually is attached to that vestibulocochlear nerve. So here's another picture of the anatomy of the cochlea. Again, this is an anatomy course, so a lot of it is just getting familiarized with the different parts and pieces. As you can see, the spiral ganglion sits just outside and runs through. You can see the bone tissue that's just outside of this membrane and this cochlea portion. Another picture. You have your supporting cells, your outer hair cells. Know that we'll be covering this later as well. Know that hairs are stereocilia. Okay, and if I show you a picture of this during a test, you see right here, we covered this during our nervous system. This is afferent nerve fibers. So if it's afferent, right, that means it's leaving, right, it's away to the central nervous system down through here, right? And then efferent would be coming back through, right? So afferent is away. The cochlear duct, the scala media, contains receptors for hearing, and it lies between two chambers, the scala vestibuli and the scala tympani. The vestibular membrane, the roof of the cochlear duct, and the basilar membrane, the floor of the cochlear duct. I know this is clear as mud now, but I'll let you know what's important. And just understand that the cochlear duct, the scala media, contains receptors for hearing. And it's between two of these chambers called the vestibuli and the tympani. The cochlear duct, the scala media, contains receptors for hearing, and it consists of a spiral organ, the receptor epithelium for hearing. And it consists of those supporting cells that I showed you a couple of slides ago, the inner and outer hair cells, those are receptor cells, and the inner hair cells are the receptors that transmit vibrations of the basilar membrane, and the outer hair cells actively tune the cochlea and amplify the signals. So the hair cells are responsible, as you can see, and so one transmits vibrations and the other amplify the signals. So know the difference between those two. Put a red star on those. The anatomy of the cochlea overview is what we covered. Covered all these pieces. So I would read this chapter, 1619, and understand the different parts, what we mentioned in the slides. So the role of cochlea in hearing, as you can see there, you look at one, you have your sound waves that vibrate the tympanic membrane, and again, a star next to the tympanic membrane. It is a barrier, right? It's also uh, demarcates the difference between the external and internal ear. Then you have your two, which is your malleus, incus, and stapes, your MIS, and that's going to auditory ossicles vibrate and actually pressure is amplified, right? And this pressure waves goes down through here on 3, and it's created by the last portion, the last little bone there, the stapes, right? And it's pushing on the oval window, move through fluid in the scala vestibuli, right? So this is your scala vestibuli, runs down through there, and you have two parts of the sound, right? The sounds with frequencies below hearing travel through the helicotrema and do not excite hair cells, but the other ones, the ones right in the middle, um, this middle tube thing, uh, called the cochlear duct, the sounds in the hearing range go through the cochlear duct, vibrating the basilar membrane and deflecting hairs on the inner hair cells. So this would be a good slide to review the overall parts and pieces and the roles of the cochlea in hearing. And so it breaks it down pretty much word for word, and this is all you would need to answer maybe 2 questions out of this slide. The vestibule is the central part of the bony labyrinth and lies medial to the middle ear. Utricle and saccule is suspended in perilymph and the 2 egg-shaped parts of the membranous labyrinth. And the the macula is a spot of sensory epithelium. It's called the house of macula. So your macula contains receptor cells, and it monitors the position of the head when the head is still. So that's what it monitors, and it contains columnar supporting cells. The receptor cells, again, are called hair cells, and they synapse with the vestibular nerve. Tips of the hair cells are embedded in otolith membrane and contains crystals. This is important now. Crystals of calcium carbonate called otoliths. So for those of you that are doing body work and folks that come into you that have dizziness, or maybe they even have something worse, you could actually do some head movements to move these crystals around to subside some of the some of this craziness that goes on, and we'll touch on that here in the next few minutes. So the macula in the internal ear, as you can see, this top picture, and you can see it's right in the center there. That's the macula of the utricle, and then you have next to it is the macula of saccule. There's a bigger picture of it. Here's your hair cells, right? Your hair bundle, and you have your otolith membrane, your otoliths. All right, and it looks like a piece of Lego, right? It fits right on top. And you have your stereocilia right in through there. And again, look at the nerves. They're actually attaching to these hair cells, which is pretty cool. I'm glad we covered the nervous system as much as we did, because based off your knowledge, now you understand how things work. The macula in the internal ear, as you can see, the otolith membrane, the otoliths, and the hair cell. You have your head upright, the force of gravity with the head tilted. These nerves pick up and tell your brain, you know, what position your body's in. And you know, some people can get sick if this happens too fast. You know, like pulling G's and going on these circus rides. But as you can see, gravity can actually move things around, and also gravity can help heal. You know, move those crystals around. There's some movements that will show you in Tweenaw. Once you get there, there's some tests that you can run too, and use it as a diagnostic tool to see if someone has vertigo and things like that. There's also semicircular canals that lie posterior and lateral to the vestibule, and anterior and posterior semicircular canals, they lie in the vertical plane at right angles, and the lateral semicircular canal lies in the horizontal plane. So you have your internal ear again, big picture. You keep coming back to this. As you can see, the big nerves, the facial nerve, which actually diverts from there, doesn't actually go into the cochlea. But you have your inferior vestibular ganglion, your cochlear nerve, and the cochlear nerve is know that the main cranial nerve that it's connected to. All right. You have your semicircular duct that snakes through each semicircular canal, and your membranous ampulla, which is located within the Bode ampulla. It houses a structure called the crista ampullaris. And the crista contain receptor cells of rotational acceleration. And so here's your equilibrium, all right? And epithelium contains supporting cells and receptor hair cells again. Here's a better picture. You have your ampullary cupola, and this is how it all comes together. As you can see, the hair cells are at the basal layer, your supporting cells are at that basal layer, and then you have your fibers of the vestibular nerve that come up through and connect to those hair cells and supporting cells. And then your hair bundle reaches up, plus the stereocilia that gives rise to the ampullary cupola. Here's an electron micrograph of the crista ampullaris. Location, structure, and function of the crista ampullaris in the internal ear. So I don't know if, you know, I still watch Sunday. Sometimes Wide World of Sports will have these figure skaters, and man, they can spin so fast. I always wonder how they maintain their balance. Must take a lot of practice, or they have a conditioned ampulla cupula. And you know, so at rest, the ampullary cupula stands upright, as you can see, and as we move to the right, the flow of the endolymph takes place and adjusts the ampullary cupula to the side. And during this rotational acceleration, the endolymph moves inside the semicircular canals in the direction opposite of the rotation. And it lags behind because of the inertia, right? And the endolymph flow bends the ampullary scapula and excites these hair cells that are directly connected to your nervous system. And as the rotational movement slows, the endolymph keeps moving in the direction of the rotation, bending the ampullary cupula in the opposite direction from acceleration and inhibiting the hair cells. So hence dizziness, right? So here's your auditory and equilibrium pathways. You have the ascending auditory pathway that transmits information from the cochlear receptors to the cerebral cortex. The auditory pathway includes impulses from the cochlear nerve to the cochlear nuclei in the medulla. And you have your neurons that project to the superior ovulatory nuclei, and the axons that ascend to the lateral lemniscus to the inferior colliculus, then projects to the medial geniculate nucleus of thalamus and to the primary auditory cortex. So here's a good picture, the brain to the midbrain to the medulla, all the way down to those vibrations, where those vibrations take place with your afferent as they work their way up through the medulla to the midbrain, up and through the primary auditory cortex and the temporal lobe. And so that would be your central nervous system, correct? So once it leaves the brain and spinal cord, again, a quick review, it is outside of the central nervous system. So know that there's a central nervous system and a peripheral nervous system. No efferent, afferent. And let's see what's next for us. So the equilibrium pathway transmits information on the position and movement of the head. As you saw on the ice figure, most information goes to the lower brain centers, the reflex centers, to maintain your balance, actually. So your motion sickness, your car sickness, seasickness, popular theory for a cause is a mismatch of sensory inputs. You don't know what to do, which way is up. Then you have Meniere's syndrome. The equilibrium is greatly disturbed, and you have excessive amounts of endolymph in the membranous labyrinth. That's your Meniere's. And then you have deafness, which is conduction deafness, that sound vibrations cannot be conducted to the inner ear. Also, it can be per a ruptured tympanic membrane. You can have otitis media, otosclerosis, or a lot of elderly get earwax cleaned, that cerebrum we were talking about, getting it cleaned out. And man, they can pull gobs and gobs of stuff, and they can hear just fine without hearing aids after that, in a lot of cases. But then you have your sensorineural deafness. This results from damage to any part of the auditory pathway. Going on to smell and taste. It's sharp in newborns, and in the 4th decade of life, the ability to taste and smell declines. So, and we're reaching towards the end. What happens throughout life? Our photoreceptors are fully formed by 25 weeks, and as an embryo, and all newborns' eye are hyperopic. By 3 months, image can be focused on the retina, and by 6 months, the depth perception is present. And all those senses are working together at that point. With increased age, the lens loses its clarity. The dilator muscles of the iris become inefficient, and visual acuity is dramatically lower in people over 70. Hearing in the newborn, responses to sounds are reflexive, and low-pitched and middle-pitched sounds can be heard. So it's pretty interesting how newborns develop, and these senses learn to adapt and develop, and how things change. But in the elderly, hair cells are gradually lost, and the ability to hear high-pitched sound fades. And you have presbycusis, which is a gradual loss pardon me, of hearing with age. So this is what we covered of the special senses, and we did a quick review. Know the hand bones, pardon me, a second here.